Hello, my name is Kassandra Romas and welcome to 30 Medical Minutes. Our topic today is eminently important for both women and men, but today we will be talking to the ladies in our audience about breast cancer. Breast cancer is the most common cancer among women after skin cancer. 1 in 8 women in the United States, roughly 12%, will develop breast cancer in her lifetime. It is also the second leading cause of cancer death in women after lung cancer. Encouragingly, the death rate from breast cancer has declined a bit in recent years, perhaps due to greater awareness and screening for this type of cancer. Our guest today is Dr. Rebecca Yang, a board-certified general surgeon and a fellowship-trained breast surgeon. Dr. Yang works closely with a multi-specialty oncology team at Overlook Medical Center in Summit, New Jersey. Dr. Yang is going to describe breast cancer, risk factors, symptoms, screening processes for diagnosing, and treatments available to provide individualized and coordinated care so patients can achieve the best possible outcomes. You will find this a most interesting and valuable show, so stay tuned. And now let's welcome Dr. Rebecca Yang to 30 Medical Minutes. Thank you so much for joining me today.
Thank you, Kassandra, for having me. It's such a pleasure.
Wonderful. So, Dr. Yang, could you tell us a little bit about yourself and your background and your training?
So I just joined Atlantic Breast Associates as the director of the breast surgery program at Overlook Medical Center, part of Atlantic Medical Group. I came from Leahy Clinic, where I was the medical director for the Comprehensive Breast Health Center for 15 years, and I helped to develop the program. I trained at University of Maryland for medical school and Case Western Reserve for my general surgery and then breast surgery fellowship. And I have a particular love of New Jersey, New York, as I was a ballet dancer when I was younger, and I went to Princeton for undergrad. So
wow, what a wonderful background. And the dancing I didn't know about, but that's fantastic. Yes. That's great. Okay, so Dr. Yang, you're devoted to a very common cancer and one that strikes women and strikes fear into the hearts of women as well. Why don't you describe what breast cancer is so our audience will understand what you refer to as breast cancer?
So when I meet my patients, I tell them that breast cancer really is the abnormal growth of breast cells. It's a change that happens in a normal breast cell over time. It kind of escapes your body's immune system, and then it starts to clone itself and continues to grow. And it can take years before we actually detect it. So I use that to reassure my patients too, that when they come to me, if they felt a lump, it didn't just show up yesterday. So that ultimately breast cancer is a process.
Okay, so to repeat what you're saying, it's certain cells that have gone out of control and multiply so rapidly that they create a tumor, or even worse yet, spread to other parts of the body.
Yes.
Okay, so what different types of breast cancer are there?
So there's basically 2 types of breast cancer because there are 2 types of breast cells. One type of breast cancer is called lobular breast cancer, which grows in the cells that line the milk sacs. And the more common type of breast cancer is called ductal breast cancer. About 80% of all breast cancers are this type of cancer. These grow in the cells that line the ducts that bring milk to the nipple.
I'm going to have you repeat that for me, because you mentioned a breast, of course, has a function then.
Yes.
Which means that what we do is that we feed our babies, and that's a source of nutrition for our newborns.
Yes.
So in the milkular glands, the milk in the breast, there's the ducts that lead to it, and then there's
the sacs, or and they're called lobules. And so the cells
the lobules where the milk resides?
Exactly.
Okay. So there's 2 types of breast cancer. One affects the ducts leading to the sac, which is the lobular, or cancer within the milk sac.
Yes.
Lobular cancer.
Yes. Those are the 2 types of breast cells.
Oh, wow. All right. Are there different type of categories within those different types of cancers?
Yes, basically there's 2 categories. One is called non-invasive or in situ breast cancer, and the other is invasive breast cancer. Ductal carcinoma in situ is what we hear about a lot of. It's considered stage 0 breast cancer. These cancer cells have not yet crossed the barrier of the ducts or the basement membrane. They can't spread yet. And then there's invasive breast cancer, and you can either have invasive lobular breast cancer or invasive ductal breast cancer. And both of these cancers have the ability to spread and leave the breast.
When you describe these, are we talking about a tumor? Are we talking about a cyst? Are we talking about something that is like a sore? What does this look like?
So there's two basic presentations. One is something called calcifications that often are seen on a mammogram. Ductal carcinoma in situ tends to present that way because it really hasn't formed a lump yet. It just is starting to show signs of development of cancer. And then there's tumors or lumps. Those are growths of cancer cells that actually create something that a woman can feel or we can see on a mammogram.
Okay, so I'm going to repeat what you said once again, doctor. One is invasive, which means that, and repeat what invasive means again.
So that means that the cancer cells have the ability to leave the breast and spread to other parts of your body.
In other words, metastasize.
Exactly. And they can either spread through the lymphatics, which are part of the lymph system in our body, or into your blood through the blood vessels.
And of course, the breast lies very close to the lymph glands.
Correct. Exactly. Especially the lymph node, the main lymph glands where the breast will spread is to the lymph nodes in your armpit. On that side.
That's why when a woman does a self-exam, you do that entire area.
Exactly. You want to do that and all the lymph glands around that. Absolutely.
And non-invasive means it stays, and this is the word you've been using, in situ.
Yes.
In situ means in that site,
Exactly.
in that location.
Right.
So it's self-contained, and it's there.
And it can't spread.
It can't spread.
Right.
And that's, if somebody finds breast cancer, that's what you hope you find.
Exactly.
Okay. Are there other types of breast cancer between those other types of, those main types you talked about?
Then there are categories within those types because there's even different types of ductal breast cancers. And also there's another type of breast cancer called inflammatory breast cancer, which is a very aggressive form of the invasive cancer that is very rare, but it presents very differently because it's women present often thinking that they have a bad breast infection. Their breast gets red and swollen. And it's a pretty aggressive form that we need to immediately treat. And that's why we want to educate women that if they think they have an infection, sometimes it could be more than that, and they should never hesitate to seek out their physician to get evaluated.
Well, when a woman is breastfeeding her child, many times there will be a redness or a soreness or something like that.
Yeah.
Is that to be considered a dangerous symptom of a cancer, or is that just because of the naturalness of feeding a child and maybe a child tugging too much or something?
I mean, 99% of the time it's related to the breastfeeding, and sometimes they could have a little bit of mastitis, which is an infection while you're breastfeeding. But something that persists and doesn't go away is something that she should always, consider maybe this is not normal and talk to her doctor.
And the reason why I asked you, Dr. Yang, about different types of breast cancer is because I'm sure it's eminently important for you to know in making your diagnosis and therefore establishing the treatment regimen that you're going to be recommending.
Absolutely. In this day and age, the most important thing about treating breast cancer is getting to know all the details of that particular cancer, the biologic nature of the cancer, because we are able to individualize the care more and more by analyzing the tissue sample. And so knowing the type of cancer and different characteristics about what we call the biomarkers or receptors really guides our care. So the woman can get the best treatment for her particular breast cancer, because breast cancer is really unique to each woman. Each woman's breast cancer is unique to her.
Well, that's why it's really amazing to me that you have subspecialized just in breast cancer, because with your experience and your ability to see so many different women, you get a finer overview of all these different types.
Absolutely, and also I have such respect for the process, and It's still a challenge, and I find it also so rewarding because it's constantly changing. We're constantly updating our information so we can give the best care possible.
Well, that's an interesting point, that medical technology and information is constantly, as you say, progressing.
Yes.
And the inroads and understanding DNA and chemotherapies and everything are advancing very rapidly.
They are.
20 years ago could have been like the dinosaur era.
Absolutely, compared to when I first started training. Absolutely.
I'm not referring to when you started training. But anyway, so now we know what breast cancer is.
Yes.
Are there certain risk factors that make one person more liable to get a breast cancer diagnosis than another person?
Yes. There's two categories of risk factors that I often talk about. One are risk factors that are you bring with you to the table. They are non-modified risk factors related to your, first of all, women, if you're a woman. Age is actually the number one risk for breast cancer.
Let me interrupt you for a second. Men can also get breast cancer.
They absolutely can. They're about 1% of all breast cancer, so that shouldn't be ignored. Absolutely.
Okay. And so if they get 1%, we don't want to say that it's common, it's very rare, but it is not impossible.
Exactly.
But our topic today is women because they get 99% of the breast cancer diagnoses.
Yes.
Okay.
Yes.
So let's repeat from the beginning the risk factors. Did you say age?
Age, yes.
Oh dear.
Yes. Unfortunately, as we get older, our risk for breast cancer goes up because the main theme in risk factors for breast cancer are exposure to estrogen over your lifetime. So the longer you've lived, the more estrogen your breast tissue has experienced over your lifetime. That's why other things like looking at your history of when you started getting your menses, when did you go through menopause, when did you have a pregnancy, if you breastfed, those are things that are part of your history that you can't control but affect your risk for breast cancer. So, even though we do hear about women under 40 or younger getting breast cancer, the most common age for breast cancer in this country is over 60, actually.
That's very interesting.
Yeah.
So you're saying that the majority, the more exposure to estrogen is one of the risk factors, and that's where age comes in.
Yes.
So estrogen is one of the most critical components here.
Absolutely. Yes.
Okay. So age is one factor. Are there other factors?
Yes. Family history is very important, especially in this day and age because advances in our technology have shown that we've identified multiple genes that can run in a family that can increase a woman's risk for breast cancer. The most common genes that a lot of people hear about, I call them the Angelina Jolie genes, the BRCA1 and 2 genes that were discovered probably 20 years ago that we can screen women for and test them for. Because if they have one of those genes, then we need to put them in a regimen of screening much earlier, monitoring them for both breast and ovarian cancer. So that's a very important part of evaluating a woman.
Okay, so let's go into this a little bit more thoroughly, intensively. If there's breast cancer in your family, and we're not talking about your third cousin,
right?
We're talking about your mom, your aunt, your sisters,
or your father, even.
Oh, your father.
Yes.
Your first cousin.
That's important too if you're looking at the family tree. What is really important also is looking at the age at which they had their breast cancer. If you have breast cancer before age 50, that is a red flag for considering maybe there's a gene that was the reason they got the breast cancer.
Okay, so if it runs in the family, that is, like you said, a red flag.
Yep.
And a young woman, even in her 20s, should be very alert to the fact that her risk factor has gone up dramatically.
Not dramatically, but certainly part of the whole picture. Well, if they have a gene, yes, but if there's...
So how do you diagnose then? You said it's good to screen if there runs in the family. Are you saying a 25-year-old woman should go for a mammogram?
No. If she has a family history and there's a gene that's been detected in her family, and then she's actually tested. So you test for genes by a blood sample, basically.
Oh, a blood sample.
Yes.
Okay.
So if a woman had a blood draw that showed that she had the gene, then she would start screening much earlier than the average risk woman.
Okay, now I understand it. Okay, so we have age, we have family history. Let me see. You mentioned menopause. What?
Yeah.
And we've mentioned the word estrogen. What if a woman decides to have some replacement hormones after menopause? Does that bring up the risk also? Because there's estrogen in there.
Very good question, and absolutely. Postmenopausal hormone replacement therapy has been shown to increase a woman's risk for breast cancer. And there was a big study that came out in the early 1990s where they followed women who had taken hormone replacement therapy versus women who did not. And there was a clear increase in the development of breast cancer. So absolutely, we try to encourage women to limit taking hormone replacement therapy. As you know, sometimes you need them for the severe symptoms, but work with your doctor to minimize the time you take it, because the minute you go off, also eventually that risk will go away once over time.
Okay. So what you're recommending here, if it's necessary, not to hesitate to go on this hormone therapy process, but be cognizant that you shouldn't do it forever. Just get through the main symptoms and then ease off.
Yes, although you really want to try to find everything else but the estrogen replacement initially. Try to work on other more natural things like vitamin E. There's things like black cohosh, but if it comes down to, you can't be miserable either, but definitely always remember we want to try to limit the time frame you're taking it. So.
Wonderful. What about the environment? Like everybody always talks about there's stuff in the air and everything like that that's causing cancer. Is that true?
I definitely think there's an element of the environment that's affecting our risk for breast cancer. There are a lot of things that act like estrogen that we are exposed to, like pesticides on the lawn, your dry cleaning products sometimes, and a lot of times before they change the plastic composition, the BP products were shown to act like estrogen. So I think there's a lot more out there that they're still working on to identify. Absolutely.
Oh, okay. Yeah. So we have to be careful of all those things.
You should try to, take the plastic off your dry cleaning. Try to, use a water bottle with glass and aluminum as opposed to plastic.
Okay, those are nice little tips. What about a person's size? I mean, does a person who have a small breast as versus a person who has a fuller chest have a greater chance of getting cancer, breast cancer?
So the size of the breast is not so important as actually her weight.
Her weight?
Yes.
You mean her general weight?
Overall general weight, yes. We talk about obesity and BMI. So being overweight is a known risk factor for breast cancer, especially after menopause. Because again, in the theme of estrogen exposure, when you go through menopause, your ovaries aren't making a lot of estrogen, but the source of estrogen for women is in our fat cells. So
really?
Yes. And especially your abdominal fat region. So those fat cells are the source of estrogen. So when you have, and it's like taking hormone replacement therapy in a certain way after menopause. So that is more estrogen that you would normally have, which can also increase your risk for breast cancer. So.
Wow, Dr. Yang, I think that all of us have just learned that fat cells actually create estrogen. And as we grow older, we get this middle tire thing. That's not so good. So I suppose keeping our weight under control is a good way to reduce our risk for breast cancer.
Absolutely.
That's what you're saying,
Absolutely, among many things. So it's very important to try to keep a normal weight.
Okay.
And even, so part of that is, exercise and diet, obviously. And actually, exercise has been shown to reduce estrogen levels in the bloodstream, too.
Oh,
so it's a benefit of keeping your weight down plus reducing estrogen exposure.
As well as keeping your muscle tone great.
Exactly.
All right, good. And your energy level up.
Yes, and mental and physical health.
Okay. So. How do you diagnose breast cancer then? How do you go ahead and then from there we'll go into treatment?
So the diagnosis of breast cancer is based on, either a woman coming and noticing a lump that is new, or something found on a mammogram that is abnormal. The most common type of patterns that we see on mammograms that lead to a biopsy are either you actually see a lump, or evidence for architectural distortion, or sometimes a certain pattern of calcifications that can be seen on a screening mammogram. Calcifications are very common. Most women have calcifications on their mammograms, and but it's only certain patterns that alert us to say, hey, what's going on in that area? What's the change that could be potentially, a sign of early breast cancer? So in the way once we see something abnormal, then the next step is to do a needle biopsy. You want to get a sample.
A needle biopsy.
Exactly.
Okay.
It's called a core needle biopsy, not surgery. We never jump into surgery as the first step to figure out what's going on. We want to start off with the least invasive procedure to get all the information, do an analysis.
So with the biopsy, the sample is sent to the lab.
Exactly.
And do they evaluate the cell types and everything? Is that what they're doing?
Yes, exactly. They tell me, is this a ductal cancer? Is it lobular? Is it non-invasive? Is it invasive? And they look at certain biomarkers. We look at, do these cancers feed on estrogen and progesterone, and also another receptor we look for called the HER2/neu receptor. All that information we can get from the core needle biopsy.
Okay. And you mentioned surgery. Is that necessary as well to do a biopsy ever? Excuse me.
So in general, the next step after you've confirmed that you have breast cancer is surgery, because you need to remove the tumor and you need to remove often remove some lymph nodes at the same time, because that enables us to stage the cancer. And that gives us the final kind of picture of the woman's breast cancer to guide all the other care that we want to give her to help prevent the breast cancer from ever coming back. And that's called adjuvant treatment.
So we're talking about breast surgery, and this is what your expertise is. That's your specialty.
Yes.
I think every woman has that fear that breast surgery is major, that mastectomies happen. You mentioned Angelina Jolie. She had a double mastectomy.
Yes.
But it isn't necessary, you're saying.
Surgery is essential in removing the tumor and getting all the information to cure the patient, to give her all the other treatment that's going to prevent her prevent it from recurring.
Okay. So when you go in for surgery, you're going in either to remove a tumor, which is maybe self-contained, as we said, and encapsulated. And if you remove it, then that's a successful surgery. If you go in and you see that the tumor has spread, or what happens then?
So if you have an invasive tumor, you also you can still do a lumpectomy. You can still just remove the lump.
Okay.
But you also need to add another part to the surgery. We always remove some lymph nodes in the armpit on the same side to help, see if it spread to the lymph nodes, because that can affect the medical treatment, the systemic treatment for the cancer.
Okay. I know you mentioned that earlier, but I needed you to repeat that because it's such a complex type of thing.
It is. It's very complex.
And I think we as women need to know that when you do your surgery, you're going in there to remove all of it so that it does not return, that there isn't a relapse in any way.
Right. That's why when you remove a lump, you always want to get what we call clear margins. So you take the tumor out and get a rim of extra tissue around it to get it completely removed.
Okay. So after you've gone in and you've either removed the tumor and everything, what sort of treatment will you recommend at that point?
So if you have a lumpectomy, which is called breast conserving surgery, which thankfully almost 80% of our women are able to have because we're catching breast cancer early, you need something else to protect your breast from the breast cancer coming back. So then radiation treatment is part of that. And then depending on the type of tumor and what the receptors are, oftentimes most women have what we call hormone receptor positive breast cancer that feeds on estrogen, so we will give them an anti-estrogen pill that they're going to take for 5 years. And sometimes they may need chemotherapy too, depending on what the final staging is and the biology of the tumor. But thankfully, with advances in our understanding of breast cancer, fewer and fewer women actually need chemotherapy. But when they do need it, we can target it even more specifically, especially for some tumors that are called HER2/neu positive breast cancers. About 20% of them are that type of cancer, but we've advanced our care so much we have targeted therapies to attack that receptor. So the treatment is very hopeful.
Okay, so I'm going to repeat what you just said, Dr. Yang. The progress in medical and chemotherapies had advanced so much that you can evaluate the type of cell that has caused the cancer and your chemotherapies are now targeted to eradicate just that type of cell, and not, as in the old days, all the cells around it.
Yes, certain targeted therapies do that, but still some of the chemotherapies we have to give are not as targeted, so they still affect the normal cells. So unfortunately, still some of the side effects that go with chemotherapy still happen, like the hair loss, losing your hair, the nausea and the vomiting, and sometimes the immune system. But we have other treatments to help alleviate those symptoms as well. And
Yes.
there's great.
So in other words, the treatment and your treatment of the side effects have advanced so greatly.
Absolutely.
And is the regimen reduced in time as well? That in the old days it could be months and months that you'd be going through this. Has it been reduced in time?
There's also been reduction in the time frame. Oftentimes now you have your treatments every other week. They used to have 6 months of chemotherapy. It used to be that you went to the hospital for chemotherapy. Now it's outpatient. We try to have it as least impactful on a woman's life. I mean, we try to encourage women, if they can, continue working, continue doing their daily activity. There are women out there that are getting chemotherapy you probably don't even know, because we're able to really manage those side effects and the symptoms and help them live their lives.
That's really encouraging to hear. So when should a woman go for their mammograms? At what would you recommend at certain age categories?
So if you're a woman of average risk, no major risk factors, the recommendations are start a routine screening mammogram at age 40 and have it once a year. For women that have been identified to have a gene for breast cancer, we do recommend that they start screening breast MRIs at age 25 and start mammograms at age 30.
Okay.
Okay.
And is that annually or every few years or whatever?
So annually.
Annually.
Yes.
Okay.
Yes.
Okay. Very good.
Yep.
One more thing: there are support groups for women who do have breast cancer or recovering from breast cancer, and then those who can mentor people who are going through that. Is that correct?
Absolutely. Especially at our cancer center, we have a wonderful program of a nurse navigator that meets with every single woman who's been newly diagnosed with breast cancer to help guide her through the journey and provide support groups. We have, and there's a wonderful program from the American Cancer Society called Reach for Recovery that pairs women with women who are just going through breast cancer with women who've gone through it of similar age and type of cancer, if they have any questions, to provide support. So there's a lot of support out there.
Well, this is a wonderful overview of breast cancer, Dr. Yang. We really appreciate your coming here and explaining it to us. And it's wonderful to know that there are people who will assist you in the whole process all the way through. You're not alone. Somebody will hold your hand, help you even make your appointments for you. I think that's the nurse navigator. And there's support groups that get you through it afterwards.
Absolutely. It's a journey, and we're there for them for the entire journey.
Thank you so much. And thank you for joining us today on 30 Medical Minutes.